Hey, it's Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC. Today I'm talking about the top 3 now fixes that we should be absolutely jumping on to help healthcare in Canada. I mean, hey, if you're a Canadian and you still have a pulse, you know we could do better in the healthcare system. But often it's just too much talking and it's hard to know where to get started. So if you like 90s country music and you remember Toby Keith, hey, let's have a little less talk and a lot more action. All right, so I'm an MD. I'm a system insider. What would I do right now to get on this fix? So if you've got 10 minutes, stay to the end. Number 3 is going to surprise you and it's going to challenge you. It's going to make you think. Here's number 1. Number 1, we gotta work on this bureaucratic quagmire that just is everywhere. It's like quicksand. You're always stuck in it. So I live and work in the interior health system, and I'm not here just to rain on them, but it's just a health authority with a ton of people in middle management that have all been layered up, and everybody needs to prove that they've got some important input into this system. So, even though we've known for 5, 6, 7 years that our local CT scanner was outdated, not what we needed, not up to snuff, not giving radiologists the kind of high-grade images that would be the best medical care, hey, we had the ability to fundraise to get a found allotment so that we could get the best machine right away. No, every year we get told just time out, pause. It'll happen next year. Somewhere in the system we'll make it work. Oh, I go to a meeting and they say, well, we're only allowed to kind of work on one CT scanner every year. What? I go to a meeting and the CEO is saying, well, we thought about it. We know we said you guys are probably going to be completed in 2025, but nope, can't. We can only do this one other place. And you sit there and you give all the persuasive arguments and you explain how, well, wait a minute, we're way behind in our ability to do the kind of things that 2025 technologically is capable of, and there's going to be all these funding freezes in place. And so you make persuasive arguments and you think just for a moment, yeah, you've persuaded the decision makers. You've got the CEO talking to the VP finance and they're going to do some things in the background, and that's exactly what they say. And still 8, 9 months later, we're stuck waiting, and the last I heard just this past week, maybe next April or May. Holy Dinah! If you were a farmer and you needed a new combine to get the harvest in, you'd go and figure it out. You'd get the financing and you'd get things done. If you were a private contractor or a business person and you needed a piece of capital equipment in order to provide that quality service, you'd go and you'd get it done. I mean, I'd be willing to give it a month. It takes a little bit of time to research the product, takes a little bit of time to ask some experts. Yeah, no problem. Let's have 1 month for the decision making and the acquisition. No, we are pushing 5, 6, 7 years. And even though in January of 2025, we're like, yep, okay, we got it. We're going to make it happen. We're still looking spring 2026. And I've learned that every time you kind of have a goalpost date, add 1 year. Mamma mia, not okay. Bureaucratic quagmire. All we do is take frontline personnel, give them a title, an administrative role, make sure they have a day job, and give them one more thing to do in the system. Gotta blow it up. This business where you're always dealing with the health authority, then they're dealing with Victoria. Maybe Victoria has to talk to Ottawa about different funding streams and whatnot. Let frontline people make some calls. Let local systems innovate. Hey, it's easy. It really needs to happen. Number two is all focused on something I've been talking about for a year or two, and people are coming around to patient-focused funding. What is patient-focused funding? Okay, let's try and explain it to me like I'm 5. Parts of the health system only get paid when they do a clinical piece. Clinical piece means give a service to a patient. Jim comes in to have a surgery. Say I need my tonsils out. You don't get paid at the hospital, at the operating room, at any site. Nobody gets paid until Jim actually gets his tonsils out. Why is this important? Because the way we just do block-based funding, the way we kind of hire people and put them into roles, it's natural to put up barriers to stretching yourself. It's natural to say, well, we don't really want to push the envelope. It's natural to say, well, I don't know about that innovation. It's natural to say, yeah, if we only have to do 8 things today instead of 10, that'd be better, right? We'd all feel warm and fuzzier. Yeah, I know. So, like, if you want to push and you want to get the best outcomes for the most number of people, you have to incentivize the actual providers to innovate, to create efficiencies, to be motivated. So the classic case of an operating room is if you can come up with systems where instead of the 15 or maybe 20 people who can get a cataract done on any given day, if you could even get 10% more, say 2 more people, well, that's better for everybody, right? And that is the beauty of patient-focused funding. If the people in the system, if the program in the system, in this case it's the operating room and all the different focus and component parts that are incorporated into an operating room, that could be staff, that could be capital, that could be all the space and that kind of thing. If they get more from the funding mechanism, from the government in this case, because they're able to create innovative approaches and do more at a high quality level, then that program gets paid more. And that really has to be the new focus for everything. So Jim, a person with a healthcare number, a person who pays taxes in British Columbia, when I access the healthcare system, that generates a clinical activity, and then that portion or that part of the healthcare system gets paid. It's just kind of logical, except nobody knows how healthcare systems work because they're these great big mega entities and they're all supposedly funded by the Minister of Health way off yonder in Victoria. But, there's so many tentacles and the natural focus is inertia. Gotta have something that breaks out of the inertia. That's number 2. Number three is I actually see a real need to optimize patient trust in their providers. What am I talking about? So patients need to trust physicians, nurses, all the auxiliary and parallel healthcare providers that are built into the system, right? So if you'll indulge me, I'm a physician. Let's just talk from the physician point of view for the moment. Patients really need to trust that you have their best interests at heart. And here's one thing that I have seen that is becoming a real poison pill in our system. And it's medical assistance in dying and the way we're talking about expanding it into psychiatric illness, even considering it for mature minors. And as an emergency doctor, basically every shift in a busy emergency department, you have at least one patient who expresses suicidal ideation or suicidality. And now I'm starting to hear some of those people say, well, maybe I should just get made. Okay, where's the distinction between committing suicide and getting made? There isn't any for me. Like it's not got a logical distinction where you can tease it out. And this is the Pandora's box that we've opened when, I think it's 9 years ago now, we allowed this. It seemed to many people a compassionate thing to do, to say, well, we'll keep suffering out of your last few days, weeks, or end of life issues after you've had a terminal diagnosis. Except we opened that door. We said, well, that's okay as a society. And now so many other considerations and options are being pushed in through that neighborhood where we're like, well, we couldn't exclude this kind of case or we couldn't exclude that kind of case. And we're creating very much what I see as an ableist part of society. That people are starting to get the message that I'm not worthy. I maybe am not functioning at my best, or, I've got this long-term thing now, and, my kids or my family members are kind of feeling burdened, and it's not okay. Not okay. So bottom line is, we got to make a big cultural decision about how we're going to approach this. Because my take is, are we all created in the image of a higher power, the image of God? Or are we all just kind of functional pieces and some of us lose our worth over time? It's eroding confidence in providers, and it's not going to work big picture. So we got to do something about that. Hey, those are my top 3 right now fixes, but I want to hear what your number 1 fix is. What do you think about the 3 that I gave you? You got a strong opinion? Can you see a tweak? Do you have a better idea? That's why I do this content. I want to hear what you're thinking. I want to hear what folks are grappling with or considering. Let's work together to transform healthcare in Southeast BC. You be part of it. So drop me an email. Connect at jimwiedrick.ca, CONNECT at JIMWIEDRICK. Cheers.